morning. We'll start the session. The session is on ocular trauma, special scenarios. The first speaker is Dr. Yasar Safar. His topic is on traumatic retrobulbar hemorrhage, intraorbital foreign body and animal bites. He is a consultant in orbit and oculoplasty at Agarwal Eye Hospitals, Trivandrum. Over to you, Dr. Yasar.
Good morning, warm welcome. So this being the first session, we'll go on to the topic straight away. So we'll be discussing on orbital trauma, especially retrobulbar hemorrhage, orbital foreign body and animal bites. So retrobulbar hemorrhage, as known, it's an accumulation of blood in the retrobulbar space, which is a rapidly progressing sight-threatening emergency. The main cause obviously being trauma and periocular injections and surgeries. And sometimes it can occur spontaneously also in especially patients with uncontrolled hypertension, septicemia, etc. The signs and symptoms being periorbital pain, periorbital ecchymosis, eyelid hematoma, ophthalmoplegia, proptosis, sudden visual loss, and subconjunctival hemorrhage or hemorrhagic chemosis. And the patients will have severe nausea and vomiting also. Why is it an ocular emergency? To know that, we will have a quick recap on the anatomy. The orbit being an orbital volume being 30 cc, being enclosed 360 degree mostly by the bone, and only the anterior surface being open, and has rich vascular supply also. So any bleeding into the orbital space, which being a source space, can lead to can lead to accumulation of blood in the orbital cavity, which lead to orbital compartment syndrome. Any bleeding in the compartment which leads to optic nerve stress and damage, and which eventually lead to ischemic vaso-occlusive crisis, including CRAO. So when a patient presents with any history of trauma or any periorbital injections or surgery, if the patient is presenting with acute onset of pain, proptosis, periorbital ecchymosis, and sudden drop in vision, you should immediately measure the visual acuity, intraocular pressure, and have a comprehensive ophthalmic examination of the patient, including ocular motility and fundus examination. Look for spontaneous venous pulsations and spontaneous arterial pulsations also. If possible, try to measure the intraocular pressure. And severity of the RBH can typically be determined by the physical examination findings rather than any imaging studies. It's a sight-threatening emergency, and clinical diagnosis is the dictum, and it needs emergent treatment also. Imaging is not recommended for initial diagnostic purposes. CT scan may be done to visualize the orbits, particularly to rule out any concomitant injuries also. So if you diagnose a retrobulbar hemorrhage, be a ninja, there is no time to wait. The intervention should be rapid within 2 hours of onset to avoid any permanent damage. Surgical management is preferred, or medical management, and concomitantly you may give IV acetazolamide or hydrocortisone. The first line management being lateral canthotomy and inferior cantholysis. So give local anesthesia to the lateral canthal area, crush the lateral canthus and cut it with the scissors, whatever you have in the OPD or in the minor OT. No need to take the patient to the OT even, because it's an emergency. And if the pressure is still not relieved, you can do inferior septectomy and infralateral orbitotomy if needed. If the time has been elapsed and the blood might get entrapped within the numerous fibrous septae within the corner space. In short, it's the hemorrhage in the posterior muscle cone. It's a space occupying lesion which leads to sudden proptosis, pupillary dilatation, reduced vision, high IOP, and eventually lead to permanent visual loss. Coming to orbital foreign bodies. Orbital foreign bodies are any foreign object, partially or completely within the orbit. It may be there with or without penetration or perforation of the globe. And it can either be purely orbital foreign bodies, or it can be transorbital foreign bodies, where it can reach the adjacent space like intracranial space or paranasal sinuses. Or it can be either occult or overt foreign bodies too. So the etiology being most commonly being any trauma, especially accidental injuries or industrial accidents. Sometimes it can eventually lead from assaults also, domestic and motor vehicle accidents, high velocity projectile. Sometimes it may be diagnosed incidentally. The patient might have forgotten the history of trauma, especially if they have some sharp injury, having a self-sealing wound, which should have lodged the foreign body within the orbit. As in any trauma, it most commonly occurs in young men, working age men. It can be either metallic or non-metallic, or even organic materials also. So 89% of the ocular orbital foreign bodies are associated with other ocular injuries like corneal aberration, iritis, retinal detachment, and commotion retinae, and 7.4 are associated with open globe injuries. And transorbital foreign bodies are also there, wherein it can lead to paranasal sinus or intracranial cavity also. So the pain symptoms as such are visual disturbance, pain, swelling, droopy eyelid, double vision, and sometimes if it's an overt occult foreign body, it can be asymptomatic even. Make sure that you take a proper history, the history like what is the mechanism of injury, like a projectile injury or any strike on metal will obviously have some metallic foreign body lodged within. And if you notice any entry wound, make sure that you suspect a foreign body unless proven otherwise. Rule out open globe injuries and traumatic optic neuropathy, and make sure that you examine the upper cranial nerves also to determine the penetration to neurological status of the patient. Orbital foreign bodies are often difficult to diagnose, and you should have a high index of suspicion in any patient with orbital trauma with any periorbital penetrating wounds. And it may need multiple examination and additional imaging for the diagnosis. So plain x-rays may be taken as a screening test, especially in the OPD setting if you suspect a metallic foreign body. CT scan is the first line imaging. CT scan not only of the orbit, but you should make sure that you take a CT scan of the orbit along with the brain. It's a first line imaging study after the trauma. And make sure that you communicate properly with the radiologist. As in this case, it's being reported by a patient had a fall and had a nasal bleed, primarily sent from the ENT department without any proper communication, and it's reported as orbital blow-in fracture with intraorbital air pockets. And the patient, when cross-referred to ophthalmology, had significant motility restriction, and when the CT imaging was reviewed, there was a large foreign body which has pierced through the nasal cavity into the orbit. So proper communication is must, especially in organic foreign bodies like wood and organic material. And MRI is never the initial study of choice after trauma, but it's reserved for if you suspect a wooden foreign body, and make sure that you rule out any metallic foreign body before ordering any MRI. And if there is recurrent or chronic orbital inflammation where organic and vegetative matter is suspected, you can order an MRI. B-scan ultrasound can be done along if you suspect an anterior orbital foreign body, but it's highly technician dependent, and it can help you diagnose any retinal detachment or vitreous hemorrhage if associated. Plain radiographs, the problem is like it may underestimate many materials like graphite, plastic, fresh or dry wooden foreign body, etc. Management: most foreign bodies are metallic in nature, but they are relatively easily visualized on imaging, but it's not the same way while in RAW, because orbit as such every all time it says a Pandora's box. Surgical options, so it should be individualized, and you should weigh the risk of surgery as in and the risk of retention. Weigh the risk of surgery and the risk of retention as like infection, inflammation, and fistula formation. Open globe injuries should be immediately repaired before exploration for the orbital foreign bodies. So surgical intervention absolute indications are neurological compromise, mechanical restriction of eye movements, development of acute or chronic infection, and chronic suppurative reactions to foreign bodies. Small, inert, and deeply lodged metallic materials may be managed conservatively, and it will be well tolerated if left in place, and the patient will be advised no further MRIs. Most metals are inert, but some may lead to serious complications, especially lead, copper, and iron. Larger foreign bodies have a higher risk of penetrating into the surrounding structures, and surgical removal should be attempted. Meticulous planning should be done before executing the removal of the foreign body. Organic foreign body, there is no choice, you have to remove it completely. If observation is preferred, the patient should be notified and carefully monitored, as it can lead to chronic inflammation, abscess, and fistula formation, and appropriate counseling should be done for the patient, and documentation should be done for the risk of long-term infections and the migration of the foreign body. Tetanus prophylaxis has to be taken. Broad spectrum antibiotics has to be given to the patient, considering the type of injury. Anaerobic coverage and even antifungal coverage may be needed. Antibiotics with good blood barrier penetrations are recommended. A combination of third generation cephalosporin and vancomycin might help. So complications, as said earlier, infection, sinus infection, non-infectious inflammation, migration, and even gasive amaurosis can lead. So the outcome basically depends on the severity of the inciting trauma and the material causing the trauma. Anterior located foreign bodies without any globe injuries have a better prognosis as compared to the others. So prevention is always better. Periocular animal bites and injuries, it's relatively common complaint in the ophthalmic emergency room, and young children are most commonly involved. And relatively, the face and periocular regions are involved because the dogs have a predilection to bite in the face, and the young kids they are short in stature and have a poorly or a developing motor skill. So it can vary from abrasion, punctures, laceration, and even to a crush injury or luxation of the globe. So open globe injuries are relatively rare because the eye is protected within the orbital cavity, but henpecs and others can lead to open globe injuries and cat paws as such. Canalicular lacerations are pretty common, so if you find any medial lid laceration involving the medial canthus, make sure that you examine for the canalicular laceration, and if it's there, you have to repair it with silicone intubation. Orbital fractures are pretty uncommon with animal bites, but it can occur if the biting animal is large, like large breed of dog, or if you sustain any animal hoof injuries or anything like that. This patient being hit by the cow hoof. So most commonly involved bones are nasal, maxillary, and orbital bones. The problem with animal bites are the oral cavity of the animals have a pretty large lot of microbes, and the infections rates are the chance of infection is quite there. But though the documented rate of infection is less, but because the orbit and the periocular area has rich vascular supply, but if there is an infection, it can communicate with the skull base, and potential pathogen has a direct access to the intracranial space. So there are over 64 species of bacteria found in the canine mouth, and many of them are having antibiotic resistance also. So complete physical examination is mandatory. Medial eyelid laceration, look for canalicular tear, high suspicion of orbital fractures if there is any extensive orbital wounds, and you can take a diagnostic CT scan in such patients. So management guidelines, primarily being disinfection, exploration, and wound closure. So thoroughly irrigate the wound, judicious debridement of the wound, early wound closure might help. Prophylactic systemic antibiotic, amoxiclav can be helpful. If they are allergic, can give trimethoprim, sulfamethoxazole, clindamycin, Ciplox, or acetral. Tetanus vaccination has to be done depending upon the patient's immunization status, and anti-rabies prophylaxis if needed. And this is the WHO recommendation of anti-rabies prophylaxis. The face being a highly innervated area, if you see blood, it's better to give anti-rabies vaccine along with the immunoglobulin. Thank you.
Thank you, Dr. Yasar. I've got a doubt. Dr. Yasar, what about, so we see that when there is an animal bite, there is a high risk of rabies if it is in the face. So normally in the other extremities and all, you infiltrate immunoglobulin at the wound. So what do you do in case of eyelid injuries?
It's better to infiltrate, ma'am. So there is, as such, the WHO recommendation is there is no need to even to test for allergy. You have to infiltrate. The face, hands, and neck region are highly innervated, so even despite not even to check the immunization status of the biting animal, you have to give anti-rabies vaccine along with serum.
If there is no lead injury, but it's mostly a globe injury, what do you do then? Any infiltration is given like that in the immunoglobulin?
Not
only in the skin part it is
lid
given.
part we do give.
Okay. Thank you.